Good evening to one and all. Welcome to today's session. Today's session is on brain death and preparation of the organ for donor transplants. The speaker for today is ma'am. Ma'am is Dr. Sushma Gurav. She is a senior consultant in intensive care and works in neurotrauma unit at Ruby Clinic, Pune. Apart from that, she is also qualified in medical legal law, which is very pertinent to the topic. And without further ado, I'll hand it over to you.
Thank you very much, sir. So we start with the topic that brain death and maintenance of potential organ donor. हमने तो ट्राई किया था स्लाइड. So the topics which we will be covering is the important concepts which why brain death concept had come after such a long time. That is the concept of what has caused hindrance is with the advent of intensive care or progress in the intensive care which has interfered in diagnosing or outpassed or surpassed the cardiopulmonary death. Then we'll just peep into history and see certain definitions, the clinical test which we'll be using for diagnosing the brain death, the confirmatory test, when it should be done, and problems which will come across while performing the apnea test or while allotting the organs, then maintenance of potential organ donor, and if the organ donor has infection, then what are the issues we need to consider. Should I share it again because the slides are not going ahead?
Share it again, ma'am. I don't think there should be a problem. अभी तो move कर रहे थे.
हाँ, कर रहे थे वही तो.
आप दोबारा से share कर लीजिए.
Okay. So the issue is, this was the global data, which says that the solid organ transplant activity, so number of transplant, look at how low India is here ranking. It is how this low, and the number of N stands for the, this is for the 90 countries, and the rates are per million people. So the number of solid organ transplant activity or the absolute number of transplant in India is 7,443. This is for 21. This is the latest data which we have which is on the website itself. So the recent stat, as per the per million population, the rate of transplant organ donation, which was out on 12th August 22, is 0.6% as organ donors per million population. Whereas in countries like Spain have almost 50 million donation rate. So the brain death happens only in 3% to 4% of death. Hence, only 3 to 4 in 1,000 can donate organ. So what is the issues caused by the advent of ICU? So it is due to the attachments or the invent of the ventilators, that is a modern life supports. It has become, we can keep the patient even after the cardiorespiratory functions are not enough. We can maintain the patient for longer time, enough after the brainstem functions have been terminated. Now, the question of death or declaration of death has become important when it has become a question of resuscitation and organ donation arises. So we just go through a case, a 28-year male diagnosed to have SH subarachnoid hemorrhage grade 2. He underwent DSA. On day 2, he became drowsy. That is, GCS had dropped to 10/15, for which he was intubated. And day 3, SH scan grade 4 with intraventricular extension was seen. The clinical GCS had dropped from 10 to less than 7, and he had documented a apnea test which was positive. So what is this? So he becomes a potential organ donor, and is defined by the presence of either brain death or a catastrophic and irreversible brain injury that leads to fulfilling the brain death criteria. Now we should remember that we should have an established or irreversible brain injury cause should be there. So how will you diagnose the brain death? And so let's see what is a brainstem versus whole brain death, and what do you mean by brainstem death? The brain death, it is the death by the neurological criteria, that is DNC. It is an irreversible cessation of all brain functions, including brainstem, and that is including brainstem. The main criteria which should be there is MAP should be above 65, core temperature, and the it should maintain a normal metabolic milieu. So what important thing I told you is there should be an irreversible cause should be established. That is, it can be a trauma, like in our patient which we have SH, and hypoxic ischemic injury or infective etiology should be present. Now, when we are diagnosing or defining brain death, we should always rule out the confounders. We have to rule out the confounders. So what are the confounders? Like drug intoxications, hypothermia, hypoglycemia, hypotension. So that's what I mean by the normal metabolic milieu should be seen. Okay. Severe electrolyte imbalances and acid-base disorders. Now, whenever you are diagnosing or labeling a patient with or to have brain death, you should see that sedation and neuromuscular muscular blockades are also is off that, and adequate half-life has been passed. Many times a patient comes from outside who has low GCS, and we really don't know whether their patient has received a muscle relaxant. In that case, we need to do a train of 4 test. Okay, confounding cases like Guillain-Barré syndromes or locked-in state and high cervical spine injuries need to be ruled out. So what I said about the intoxication or the medication, so influence of central nervous system depressing medications. Now, in that case, suppose we are suspecting the patient has been given some medication from outside, or we had initially started sedation. So we have to consider the elimination half-life that can be prolonged by the organ dysfunction. So there can be an associated organ dysfunction in the patient, and hypothermia should be excluded. Now, how do you do that? We need to, if you have arrangement of serial measuring drug levels, then you should serially measure the drug levels and see to it that it falls well below the therapeutic range. Now, in that case, if you don't have a lab backup where you're not able to measure the drug levels, in that case, you are allowing 5 elimination half-lives to pass before an evaluation of brain death. Or you need to perform, in that case, you don't have that also, you don't know whether what kind of drug a patient has been given. In that case, you should perform ancillary testing in addition to the complete clinical. So clinical examination is important. You need to do clinical examination first, in which includes all the tests for the cranial nerves plus the apnea test, and that after that you have to do ancillary test. Okay, So how much observation, once the patient comes to you, how much observation period prior to clinical testing you should do? They have recommended, even our guidelines, ISCCM position statement, we have stated that a minimum of 24 hours is recommended specifically for anoxic brain injury after resuscitated cardiac arrest has been done. The time period for other brain injuries has not been established, and it should be determined on case by case basis. Okay. As a general rule, if you don't know what is the cause, so you should, and if you are uncertain about the potential reversibility of the clinical state for any reason, then the observation time should be the time is felt necessary to exclude the reversibility. Thus, what we should have an established reversible cause, absent brainstem functions, and then you have to rule out the apnea test or absence of respiratory drive on background of the factors like the milieu, which is in our body, that is core temperature should be more than 36, systolic blood pressure more than 90. I'm saying 90, MAP more than 65 is enough. Then serum electrolytes within acceptable range. Main thing occurs for the sodium, because sodium go haywire when the patient has a disturbance or is diagnosed as a brain state. There is a storm which occurs, or diabetes insipidus which sets in. So sodium level should be more than 120 to 130 or less than 160 to 170. And normal acid base status. And if the patient is alcoholic, you should look for the alcohol blood level, which should be less than 80. Now let's peep into the history. So in 1959, we have Lee Compa Depas, a state beyond coma, which was stated by Mulred and Gorman. And in 1968, ad hoc committee of Harvard Medical School defined brain death as a irreversible coma, totally unresponsive, no cranial reflexes and no respiratory efforts. So day by day, there is acceptance of brain death has been increased and accepted by the countries in the next decades after 1968. Now let's see what is the brain death versus brain stem death. This is a difference between the UK guideline and USA. In UK, United Kingdom, 1979, they published criteria for diagnosing brain stem death, and this was equated as a brain death. In 1995, we have brain stem death, which was more correct term by the Royal Colleges, but this condition is still equated to death, since there is an irreversible loss of the capacity for level of consciousness. In USA, as I said, they accept the definition of brain death. Uniform Determination of Death Act, that is the irreversible cessation of entire brain and brainstem function, needs to be documented. And this was put forward in 1981. Now let's look in India, what is the scene. So after 1981, what we did is we had passed on 20th August, there was a pass of a bill, that is the tissue Transplantation of Human Organ Act was being passed, and it was implemented as at proper in 1994. Amendments have been added subsequently. In 2011 also an amendment was added. So they defined, what we did was we followed UK guidelines. So we decided to follow the UK guidelines. Now the question arises, what comes in our mind, how much brain is needed to be dead for it to be called brain death? So we have already said that we are going to follow UK guidelines, that brain stem death. So this was a nice article which had come in JAPI. So it stated that in India, The brainstem death and brain death, although practically same with regards to the concept of organ donation, remain technically different. Brain death mandates irreversible cessation of all function of entire brain and brainstem, while brainstem death signifies irreversible damage only of brainstem. Why brainstem death was been accepted? We'll just go through the physiology and find out what is the brainstem, why brainstem death is been accepted. So the parts of brain you can see, midbrain, pons and medulla form the brainstem. So why it is important? Because it carries the fibers for attention, arousal and consciousness. So, and the cranial nerves are here, important centers of respiration, controlling the heart rate and heart functions is there. So brainstem function is vital for preservation of life. So once we have said that brain death have occurred, how we do is, first important thing we have to do is the clinical tests. So at the same time, documentation is very important and you need to document or establish a reversible cause in your documents. Then you document the blood pressures, the temperatures at the beginning of each test. Okay. So first thing you can do is you have to give a central painful stimulus. Look at it. It is a central painful stimulus. You cannot give stimulus anywhere and you will have no motor response. So where should I give the painful stimulus? So it is supraorbital region. So it is over here. Then nail beds. Then we have the sternum. Then our temporomandibular joint at the level of that. So these are the painful areas. Why? Because these are the vital nerve distribution centers, which will help us to diagnose the response to painful stimulus. Second test which we have to do is the pupillary reactions. Okay. So for that, you need to have a torch and use a magnifying glass if you are not, or you have recently we have a pupillometer is being suggested. So it should be done both. There should be absence of both ipsilateral plus contralateral pupillary response with the pupils which are fixed in a mid-size or dilated. So they are fixed, not reacting, or they need to be dilated. Now there are certain consideration we need to do, that pupil can be of any size, because if there is a trauma, it can be teared. There is a ophthalmic injury, then constricted pupils are not consistent with brain death and suggest the possibility of drug intoxications. Corneal trauma can occur in many trauma patients, and ocular installation of drugs may artificially produce transiently non-reactive pupils. So you need to find out, look at the ICU drug chart and find or rule out the installation of the drugs, in ophthalmic installation of drugs. Then in the setting of anophthalmia, ancillary testing is necessary or it is recommended. Third test which we would like to do is the corneal reflexes. So you touch the cornea of both eyes with cotton swab on stick or border of the iris by applying light pressure and observing for the eyelid movements. So no eyelid movements are being seen. Care should be taken that you do not cause damage to the cornea, because cornea can be used for transplant. Okay. So oculocephalic and oculovestibular. Then comes the fourth, where we are going to instill cold or warm saline in both the ear, one at a time. So for that, what we need to see is no wax is there, tympanic membrane is intact, elevate the patient to 30 degrees and irrigate the tympanic membrane with 50 ml ice cold water. So it's not just 10 ml. So you have to instill 50 ml ice water and observe at the same time you have to open or lift up the eyelids, and you have to look for the eye movements. You have to wait for 5 minutes before testing on the other side, because this allows for the temperature equilibrium adjustment. So normally what will happen, both normally in a living patients, if both eyes deviate towards the cold iced water. But in case of brain death, there will be no eye movements. But one should remember that facial trauma is there. There is tympanic member rupture or blood is coming. Then auditory canal and petrous bones can also inhibit these reflexes. Another test which we need to do is look for the cough and gag. And for that, we need to stimulate the posterior pharyngeal wall with a tongue depressor or suction catheter. Stimulate that, and for the cough, you can stimulate with the tracheal bronchial wall level. You can insert the catheter, suction catheter. Okay. So absence of cough and gag reflex always tells us it favors brainstem death. Now, the most important among all these tests is the apnea test. For that, the prerequisites, what you need to do is you look for the intake and output chart of the patient. Okay, patient should not be either positive or negative. You need to pre-oxygenate the patient with 100% oxygen. Okay, and you get a baseline ABG after ventilating or pre-oxygenating the patient with 100%. So what you do is you dial 100% oxygen on your ventilator, ventilate the patient for 10 minutes. And here you get a baseline ABG. After that, you disconnect the ventilator and you insert a catheter or insufflate the catheter tube or tubing inside, which insufflates with 6 to 8 liters of oxygen in the endotracheal tube to prevent desaturation. Okay. So this is just to prevent desaturation, because if desaturation occurs, we need to stop the test there and there only. Okay. Now, while doing this, what things I need to monitor is I look for a spontaneous respiration. I'll look for oxygen saturation. I'll keep eye on the blood pressure, and I should look at the ECG so that there are no cardiac arrhythmias. Now, my aim should be to allow PS. What we have done, we have disconnected the ventilator. Now, there should be a rise of CO2. What I show, it increases 3 millimeter of mercury per minute. So if I multiply, you can see per minute if 3 are there. And if I want 20 millimeters of carbon dioxide to rise, approximately it comes to 8 to 10 minutes. So you have to keep an eye both on the monitors and look at your timer. So you set your timer, and ABG is repeated at the end of apnea period 10 minutes. And patient is placed back on the ventilator. Now, what happens? The CO2 rise. Why this test is seen? We have seen when in the brain stem, we have seen the various vital centers which are being located. Now, your respiratory center should normally get stimulated with rise in CO2. So this is the speciality of the respiratory center in humans. It gets stimulated. So CO2 increases by 20 and the respiration is initiated, but in brain death, there will be no respiration. Okay. So adequate acidemia and pH, even with that 7.28, 7.30, respiration is not initiated. So this is the flow chart for the barriers of apnea test. Now, once we have done, I have told you that we have to take care of the monitor, where we have to keep eye on the blood pressures, oxygen saturation, and arrhythmias. So these itself are the barriers for apnea test. So first important thing for barrier is the hemodynamic instability. All these patients who are heading for brain death or diagnosed brain death will have ionotropes. So hemodynamic instability is one of the drawback which will prevent us from doing apnea test. So what I need to do is you add the vasopressors, inotropes, fluid resuscitation should be done, hemodynamic monitoring, we will see what are the monitors which we need to do. And if not, the patient is not responded, has not responded, you need to give HRT, that is hormonal replacement therapy. Okay. Then pulmonary dysfunctions. Neurogenic pulmonary edema can occur due to the sympathetic storm which occurs. Then for that, what we need to do, our patient may have a diagnosis of ARDS. In that case, you pre-oxygenate and apneic oxygen. So you pre-oxygenate plus apneic oxygenation during the apnea test, or you maintain the PEEP during apnea test, plus there are recruitment maneuver should be done before the apnea test, and you can have a PEEP valve over there. So we will see the problems which we are facing during apnea test. Second important thing, if patient has underlying COPD and his baseline CO2 is already 70, 80 or 60, so then what do we do? So you have to target a high CO2. The difference between the baseline CO2 and the CO2 after apnea test should be again 20. Okay. Other factors like acidosis are, if they are there, you need to have a supportive care. Always, if in doubt, please wait, stabilize the patient, because caring for a potential organ donor is caring for the lives which are for those patients whom the organs are going to be transplanted. So if your apnea test is successful, yes, it is a brain death. There's a nice article which says optimizing apnea testing in determining the brain death, which has covered all the barriers and the management parts. Now, beyond this, what I can always say that it happens that you have initiated the apnea test in the beginning and your patient is stable during that. But once you initiated after 5 minutes, 6 minutes or 3 minutes, 2 minutes, what happens is there is a blood pressure drop which can occur, or patient is desaturated. But make a point, you already have a baseline. Whatever the timing is there, try to collect an ABG. So for doing apnea test, you need to have an arterial line. Okay, you need to have an arterial line. We will see in the hemodynamic monitor what other gazettes we need in this. So you need to have an arterial line and you should be ready for taking a sample. So the moment patients start desaturating or the blood pressure starts dropping, you take an ABG, whatever is the timing or interval we have got, you collect it and you send for the ABG sampling. Okay. So the problem encountered one is there is high PEEP requirement is there in the patient. As I said, in this, the barrier, pulmonary dysfunction, and there is hemodynamically unstable. You can always start the inotropes or vasopressor, give adequate fluids, and markedly acidotic from the metabolic derangement. So what I can have is the PEEP valve for apnea testing is there, or ancillary. This PEEP valve is used also for transporting the patient. So, or you need to do ancillary tests. So this is the PEEP valve which can be attached to the endotracheal tube. Okay. And oxygen supplement can be added to the other end. So this is the PEEP valve which maintains, or you can do a recruitment maneuver before disconnecting the patient. Okay. So problem 2 is many times you will see a reflexly, you have disconnected, you are doing apnea test and there are spontaneous movements. So what does it occur? The patient as if he gets up. So brain death is just at the level of brainstem. Beyond that, that is at the C2 level, you have no control. So these are the triple reflexes at the level of ankle, knee, and hip. The patient as if he gets up. So this is called a Lazarus sign, and this occurs due to the abdominal flexion, adduction, and flexion of the arms can occur. In that case, still you can do confirmatory test. So who can declare brain death? So a doctor in charge of the patient, under whom the patient is admitted, or a doctor in charge of the hospital, an independent specialist of unspecified specialty. So this has been added in the amendment that anesthetist, a surgeon, an intensivist can also have, if their names have been approved by the authority or organ donation team in their hospital, which has been approved by the center or a regional or state organ transplant center, then he can also declare the brain death. And the other things, the neurologist or the neurosurgeon. So this is the thing which I would like to add. It is recommended that determinants, the brain death or determinations can be performed by the practitioners who have completed training and are licensed independently to practice medicine. First thing. Second thing, periodical certification must be needed because we need to verify all their documents time to time. First thing. Second thing is they need to be updated with the amendments. Third thing is they should be trained to deal with the catastrophes which occurs after brain injuries, and they should be educated. Important thing is about the counseling families in the end of life care. So they should be educated for this. An important thing, these practitioners or these doctors, is they should have effective communication skills, because they are going to with the families, and they should be so aware of, they should develop an effective communication skills. So this, when we know that, what exactly is the brain death donor management process consist of? So first thing, whenever we have an established cause, solid established cause is there is irreversible level of consciousness, you have done the clinical testing and you know it is a brain death. So he becomes a potential organ donor, you need to maintain him. So you have to notify, what I have to do is, I have to notification of potential brain death. So you have to notify all your staff members plus the social workers, and then they notify the regional donation coordinator. So what happens is, organ procurement coordinator dispatch and patient assessment has been beginning. So patient assessment is done by the practitioners or by the medical staff, and you have to see the suitability, okay, whether the patient is suitable. So you have to interview the guardians and obtain the consent. So when this consent can be done, once you have done the clinical examinations and you discuss with the patient relatives. So when this has been done, you have to give emotional support to them. So there is a loss to them, their family. First, so first brain death examination has been done. You confirm the prerequisites, then you do the brainstem reflex and apnea test. After 6 hours, you repeat the apnea test. So apnea test in all, we follow the UK guidelines. They do only one test, but we in our country, we do 2 apnea tests 6 hours apart. Okay. And there is organ procurement surgery. So this is the long chain we need to follow. And in between this, care of this potential organ donor needs to be taken, because any event, any deterioration will hamper our program. Okay. At the same time, we need to maintain the family's emotions also, or we need to give a emotional support. So when can the certification done? Now we know that this is a long process. So certification in India, after you do a second apnea test, the apnea needs to be repeated after an interval of 6 hours. In US, they do only one apnea test. And in UK legislation states that second apnea test can be done at any time. So maybe 1 hour, 2 hours, or 3 hours. So after the first, when the blood gas has been normalized. Okay, so this is for the UK. But for India, we do 6 hours apart. Okay. Now, so when are the confirmatory tests required? So clinical tests are must before we go ahead with confirmatory tests. So in this, if the patient's instability is being seen, that we cannot disconnect the ventilator if FiO2 requirement is hard. We have 3-4 inotropes. We have attempted twice and the blood pressure becomes drops each time or desaturation is occurring. So in that case, or we are not able to do the eye testing, like eyes are swollen, raccoon eyes are there, or there is accident and facial-maxillary injury has been done, then rarely family can demand. So what are the tests we need to know? That is, EEG is the isoelectric and non-reactive EEG. We have bedside EEG machines are there, but we should remember that we have many gazettes attached to the patient. So the monitor is attached, the ventilator is attached. So all of this can cause an artifacts, and it tests only the cortical functions. It is not going to test the brainstem affected by sedation and hypothermia. Then we need to other test is the cerebral angiography. What happens? So this is not affected by sedation and temperature. So lack of perfusion, intracranial perfusion or empty skull sign is being seen. And you can also do a bedside transcranial Doppler where there is absence of diastolic or reverberating flow. So when you put your probe, so you'll find the absence of diastolic or reverberating flow. It is safe bedside, requires bone window, but and a skilled technician is needed. Other thing is the somatosensory evoked potential or nuclear scintigraphy, where you can see the empty light bulb sign. Okay, so these are the confirmatory tests and only been carried out what the certain conditions are there. But with this, you need to do clinical tests are must. Now we go ahead with care of potential brain death organ donor. Okay. Now this is the simultaneous care for. Why it is important? Because it is a care of multiple recipients on the other side. And in the donor, we have fluctuating hemodynamics are being seen. And this occur because of the inevitable hormonal imbalance, the inflammatory changes which we are going to see, which accompany the brain death and can result in graft dysfunction and increases in chances of rejection. So we don't want this to occur. Already our organ donation rate, we have seen it is a minuscule. And on top of that, if you don't give care or proper care to this potential organ donors, it will create a havoc. So our waiting list for organ transplant is huge. So we need to help those multiple recipients by giving a proper care for this potential brain dead organ. So these are the various articles which are very interesting, which have helped me to prepare and our own guideline which I have been using. Okay, so what are the workup we need to send in this when we are preparing or giving care? So first important thing, you need to have a height, measure the height, weight, and chest circumference. Why I am saying this is required for a lung transplant, So you need to have, even in the liver donor, you need to know the weight and height of this patient. You need to be documented, because if these organs are to be flown or taken to outside state or within the state somewhere, the coordinator from the other end always asks us about the height, chest circumference, and the weight. So you need to have documentation of this on your chart. You need to send hemogram, renal functions, liver functions, yes. Blood group, yes, you should do, because it's for all. Then ultrasound abdomen need to be done. At the same time, you need to send blood, ETT secretions, and urine cultures need to be sent. Even if the patient doesn't have underlying infection, you need to send these samples, because this will be followed later on once the organ is being transplanted in the recipient. Then the important test is Australia antigen need to be sent, core antigen need to be sent, HCV, HEV, then cytomegalovirus, IgM, IgG, both. In the cardiac patients, you need to do 2D echo. And if you want further, if the 2D echo has given us green signal, you need to do a trans esophageal echocardiography, and a chest X-ray is must. Okay. Once you have done all this, a ABG on 100% FiO2 need to be documented. That is a baseline ABG which is needed for a lung transplant. Along with that, we need to monitor the sugars, then lactates and the electrolytes need to be monitored. And the rest of the investigations should be carried out as per the organ procurement. That is, if pancreas is, then you need to send amylase, lipase and everything. As per the organ which needs to be procured, you need to do the investigations. Then nucleic acid amplification testing need to be done in high risk patients. So the case which I will continue, which we have started. So what has happened? The blood pressure has a huge surge, that is 200 by 60. Look at it. And ECG has shown the SVT and then bradycardia. So why this has occurred? So let's see. That we have to keep in mind that we need to caring for the potential organ will be caring for many recipients, and we need to optimize because the number and the function of organ suited for transplantation in order to maximize the outcome for the recipient. And clinical assessment of the organ function and response to intervention is a key to optimal donor management. Time from brain death to retrieval of the surgery or procurement of the organ should be as short as possible. So this is a chart which has shown a pathophysiology of brain death patients. What occurs exactly? So it is the baseline trauma, which a primary injury which has caused to the brain. So there will be increase in ICP. There will be a neuronal edema which causes increase in ICP, and if your cerebral perfusion pressure gets hampered or ICP increases beyond the CPP, then your brain circulation is definitely going to get hampered. So what happens is there is a inflammation or neuronal damage, and which causes ischemia, and this causes the main macrophage activation, which causes progression of brain damage and increased. This is a vicious cycle. But as the ICP increases, so you have seen there is a stretching of the brainstem, and what happens is there is a Cushing response. It is the ability of our body to maintain a perfusion to brain. So what happens is, so the blood heart, there is a increase in blood pressure, there is a hypertensive surge because it wants to maintain circulation to your brain, and reflex bradycardia will be seen. So this is Cushing's response, which tells us that there is a progressive brainstem ischemia occurring. You can see over here. So brainstem is initially fine, the stretching or due to the raised ICP. So slowly your brainstem gets ischemic or brain death occurs. And when this occurs, you have a sympathetic storm which occurs, and it will cause, what does the sympathetic storm causes? It has main two side effects. It will affect the heart, first thing, and it will cause an alveolar epithelial cell damage. That is, sometimes you get a neurogenic pulmonary edema which occurs, and here your oxygen requirement can increase, or this causes a imbalance, say desaturation. So you need to maintain a proper oxygenation. And in the cardiac insult which is occurring due to the sympathetic surge, there can occur stress cardiomyopathy. So due to the increased sympathetic surge, there is increased afterload, arrhythmias can occur, ischemia can occur, and necrosis, or as I said, stress cardiomyopathy can occur. Then once this has exhausted the sympathetic surge, or the sympathetic as norepinephrine, it has exhausted, then what happens is you get hypotension and bradycardia, and there is a reduced cardiac contractility. So this is the further stage, and in this case, further if you have hypotension, it will reduce the brain circulation. So as I said, this is a vicious cycle. So important thing is you need to take care of the sympathetic surge. During that phase, you need to take care of the heart and lung. And after the sympathetic surge, you need to will have again hypotension and bradycardia. So again, taking care of oxygenation and heart. Okay. So hemodynamic effect we have seen. It occurs due to the medullary ischemia, and we need to take care of this surge. Okay. So challenges, this is one of the challenge, the important challenge in maintenance of organ perfusion. So respiratory system, we have seen it causes due to the, there can occur pulmonary edema. So various causes. For the hypotension reflex, you have given adequate fluid, you have given a fluid challenge. So excessive fluid also can cause pulmonary edema. It not be necessarily be due to the sympathetic storm. So endocrine system, which disturbances occur or metabolic responses. So your posterior pituitary function is lost. So what will happen? The enzymes which have been secreted by the posterior pituitary, that is diuretic hormones, then control of the thyroid hormones and this insulin level stimulator, this all gets affected. So what will happen? So diabetes insipidus sets in, there will be excessive diuresis, polyuria will occur, you will lose lot of fluid. So hyponatremia because of the sodium retention. Then there will be due to the thyroid hormone level decrease, again it will cause hemodynamic instability. Then loss of insulin levels are there, so hyperglycemia sets in, and there is a loss of temperature control regulation center is lost, so you will have hypothermia. But the important side effect of hypothermia is it causes worsening of acidosis, coagulopathy, and there can occur arrhythmias. Okay, and there is a cold induced diuresis. At the same time, we have seen in oxygen dissociation come, there will be shift of leftward shift in case of hypothermia and acidosis. Okay, so systemic, what happens to the systemic inflammatory response? As you see, there is increased plasma level of interleukin 6 in the donor who have transplanted to the poorer graft utilization and graft dysfunction. So you need, that's what I said, we need to take care of this sympathetic surge, and there will be disseminated intravascular coagulation after the brain death. Okay, because of the release of tissue thromboplastin from the necrotic brain tissue. So our goal to maintain will be to maintain blood pressure, use minimal inotropes because organ damage should be prevented if your heart needs to be procured. Then optimizing the fluid management. For that, you need to have a baseline. You should do an echocardiography, and sometimes in case of further or hemodynamic managements, you might require a pulmonary artery catheter, can be required, indicated for donors if your ejection fraction is less than 45%. Okay, on background of cardiac and lung trans. So there is one rule of 100 which was being used initially. This was in 2006 volume, which we have seen, rule of 100. You need to, for those common, this has been used for educating those centers where we have a brain death need to be diagnosed and the patient is subsequently shifted for organ procurement to higher centers. For them, rule of 100 is been, target should be systolic blood pressure more than 100. Then urine output should be equal to or more than 100. Then PaO2 should be aimed as should be more than 100. Blood sugar targeted at 100% milligram, and hemoglobin should be 10. Okay, so avoiding lactic acidosis, maintaining proper pH and proper temperature. Okay, so other elements which need to be considered in organ management, as I said, temperature, because there is a hypothermia occurring. So it is a poikilothermic condition which occurs because of loss of hypothalamic thermoregulation. And the other thing is the patient is the ICU temperature also. So the environmental factors which also contribute for hypothermia. We are infusing lot amount of fluid to maintain the blood pressure. So this and blood products also, whenever there is a hemorrhagic shock, in that case, again, hypothermia will be one of the cause. So adverse effect of hypothermia, as I said, it will cause coagulopathy, arrhythmias, and cardiac dysfunction. So you need to use, so how do I maintain the temperature? So you need to have a warmers, or you give warm IV fluids in this patient. Okay, so these are the things. Now, which in that case, which we have seen in our case, initially blood pressure was 200. So now it is dropped to 60. What has happened? The Sympathetic storm has been exhausted and now the blood pressure has been formed because your norepinephrine, and all has been exhausted. So there is bradycardia and 16 millimeters of mercury BP is there. So what are the causes? And should I give fluid? Should I use vasopressors? So these are the conditions. So what happens? Why does hypotension occur? As I said, it is deactivation of sympathetic storms, loss of the cardiac stimulations. We might have given mannitol initially for as a brain management of brain injury, then hyperglycemia which causes diuresis, there is hypothermia which causes cold diuresis, inadequate fluid registration is being done, and because of large amount of shift or crystalloid resuscitation, there is a decreased oncotic pressure, and if it is a hemorrhagic shock, there is ongoing blood loss can occur. And we have started rewarming the patient, so it also causes hypotension, relative adrenal insufficiency as a result of trauma or the hormonal imbalance. Now, what has happened in our patient? Urine output was increased more than 300 cc for last 3 hours. Look at the electrolytes. It is hypernatremia and potassium has fallen. Lactates are 3.2, sugars are 300, ejection fraction is 40%. So what I do, I have already inserted arterial line. We have seen that collapsibility and distensibility is being seen. Then stroke volume variation was more than 100. So what do I do? So we have a modified VIP approach. This was been included. This have clearly published in the IGCCM Neuro Critical Care Supplement. I have written this modified VIP approach. What it tells us? So ventilation, infusion, and pump. That is, pump is taking care of the heart. How we are going to take care of the heart? So 3 important factors for the heart is preload, contractility, and afterload. So preload is the hypovolemia. So we need to infuse the patient. Appropriate fluids need to be taken, and if diabetes insipidus is there, we need to give vasopressin or desmopressin. So this take care of the preload or hypovolemia part. Then how I'll take care of the contractility? It is the myocardial injury you have to prevent. So sympathetic surge. So in that case, if there is LV dysfunction, the temperature should be more than 25%. 35 degrees centigrade, and adequate fluid is being given. Here you need to consider a hormonal replacement therapy, or you start the dobutamine. So this is the way you take care of the heart. That is contractility. So we have taken an afterload, that is the pressures. Here we have already taken vasopressin, which takes care of the diabetes insipidus part also, and takes care of the as a vasopressor also, it increases the blood pressure. So norepinephrine or noradrenaline is being referred. Okay. As overall, then we take care of the cardiac output, and plus oxygenation is taken care. Okay. That is, ventilation need to be taken care properly. So it is the ARDS net trial. We follow same protocol over here. So minimal tidal volume should be low, 6 ml per kg in case if there is a desaturation occurs. So we have to have a lung protective ventilation and adequate oxygenation. Okay. So mean arterial pressure should be maintained 60 mm. As I said, more than 60. Then urine output should be 1 ml per kg per hour. So if the patient weight is 50 kg, you need to have at least 50 ml per hour. Okay. Then ejection fraction should be at least 45%. And accordingly, you need to titrate. You lower the vasopressor doses. You need not keep them as high. So maintain euvolemia as far as possible during the entire donor management phase. So what are the hemodynamic monitorings? You need to have a mixed oxygen, venous oxygen saturation if it's possible. Then lactate level you need to monitor. This will be important in case both of liver. Then base deficits and acid base status. If possible, you can have in case of the lung and heart transplant, you need to have a pulmonary arterial catheter because in that case, there are a lot of fluid shifts need to be monitored and the pulmonary wedge pressure needs to be monitored. So non-invasive hemodynamic parameters also important. In that case, we have echocardiography. Echocardiography should be done once before when you are managing the fluid, and if any event occurs after it has been weaned off the catecholamines, you need to perform the echo again if there is a cardiac dysfunction, which should be repeated 12 to 24 hours following the aggressive donor management. Now, these are the various articles which have guided for the fluid management. We have seen in our patient that sodium is more than 160. So what do I do in that case? So let's remember, ringer lactates, balanced out solution are or half normal saline, they do not produce hyperchloremic acidosis. They all can be used. But the fluid which can be used, which is the choice, is 0.45 or half normal saline, because your sodium should be taken care of. In that case, you need to give 5% dextrose also to reduce as a part of treatment for hypernatremia. But let's remember, when I give 5% or when I give plain water of 5% dextrose, sugar control is also important. Okay. Now, vasopressors, which is the vasopressor of choice? It is norepinephrine, as we have seen in the sepsis. So this is the recommended predominantly in a vasodilator component of shock. But if diabetes insipidus sets in and you have to take care of the polyuria, you need to have vasopressin as a first line agent and can also serve as a additional cases for refractive shock. It takes care of your polyuria and things. So dopamine and dobutamine or epinephrine may be used in case of primary pump dysfunction. So you have tried everything. You have given fluid resuscitation, you have given all your noradrenaline vasopressors, and patient is yet not responding. You need to take care of the fluid management also, and in the end, hormonal replacement therapy should be given. So what is the hormonal replacement therapy? When it is indicated, it reduces the vasopressor requirement, increases the number of expanded criteria for donors, and improve the post-transplant organ function. So it is it improves the hemodynamics. Okay. So it has been indicated. So what is the hormonal replacement therapy? It is steroids. So recommended doses for methylprednisolone is 50 milligram per kg IV need to be given for every 24 hours. Okay. Ideally, it should be administered after the blood has been collected for tissue typing, as it has a potential to suppress the human leukocyte antigen expressions. So you need to collect the sample first and then you give the steroids. Now, thyroid hormone, is also exhausted over here. So what we give is 4 microgram T3 bolus. See, these are all IV available, but in IV drugs doses been recommended. But let's remember, in our country, what we have is oral. So we have to give T4 oral 300 to 400 microgram 8 hourly suggested instead of T3 by the NOTO, or National Organ Tissue Transplant Organization. So should be when the HRT or hormonal replacement should be considered when there is a hemodynamically unstable patient. You have tried everything, fluid resuscitation, inotropes, and your cardiac examination is seen, and your potential cardiac donor with abnormal ejection fraction that is less than 45% is seen. Okay. So what is the care for the diabetes insipidus? We have seen the urine output is a polyuric. So we are losing fluid. So sodium is increasing. Hyperosmolar sodium serum is there. Urine hypoosmolarity is there. And you need to take care of other electrolytes like potassium, calcium, magnesium, and phosphorus. So it leads to dehydration. So first is I take care of the fluid management. Second is I need to give hormonal replacement, that is vasopressin. And if it is refractory, you can give desmopressin or a nasal in form of nasal spray. It is available. You can give the nasal spray also. Okay. So ventilatory management, as I said, should be lung protective ventilation. Okay, lowest FiO2 should be used, An optimal PEEP with a restrictive fluid strategy improves the graft harvesting of lung transplant. I am not specifically giving any specific organ transplants recommendations, but this is an overall care for the potential organ donor. This is to give care so that the maximum organ can be retrieved. Need to take care of hypothermia, need to maintain the temperature approximately 36 before or during the retrieval of operation. So how do you do it? You do it by giving surface warming. These are the warm blankets or the warmers. Then you can give heat fluid warmers can be used, warm IV fluids can be used, and adjusting the ambient temperature of our ICU. As I said, hypothermia has side effects, so we should need to do. Now, meanwhile, what we have seen, our patient which was admitted with us for SH has grown Klebsiella. So what now question arises? So we need to give antibiotics to this patient, isn't it? So the question arises, in organ donor, what are the antibiotics should be given? If the patient has a small history, so you need to follow your own culture or antibiotic stewardship program, whatever you have in your own hospitals. The local organ which is there, okay, which is there. So we had Klebsiella. So what next, what we have to do is pathogen specific antibiotic need to be given for minimum 48 hours before the procurement of organs, okay. Now the question arises that if this culture report had not come previously and we had to track the culture report once the organ transplantation has been done. So what we do is the blood culture has positive after organ procurement or organ transplantation. So what I do is I need to give the pathogen specific antibiotic to the recipient for at least 7 to 14 days, okay. So where if infection is there, the organ should not be rejected. So this is for the ETT secretions. Now, so donor colonization by multi-drug resistant bacteria is done. Is not a contraindication for donation. So except in the following cases. So colonization for bacteria for which there is no efficacious treatment, and colonization of transplant of the transplant target. There is no efficacious treatment is available, and there is an invasive fungal infection. You have to refuse organ procurement for these patients, okay. For this, it is recommended, that's why it is recommended that you need to send at least 2 blood samples for culture from all the potential organ donors. You need to send the ETT secretions. It is important where in lung transplant cases also, this is more important, okay. Now, which potential donors are to be considered as susceptible for infection, okay. So positive blood culture occurs only in 20%. So which potential organ donors are susceptible for infections? In this case, older organ donors, length of stay more than 3 days, younger donors less than 40 years who have gram-positive organisms, older donors will have more than 50 years are risk for gram-negative bacteria. So these will, for younger donors, it is gram-positive, and for older donors, it is gram-negative. Studies, after doing studies, this has been revealed. So accordingly, you have to give antibiotics to the donor itself and after to the recipient also. Now you have a meningitis patient. Now in this patient, it is a SH patient, but there can occur a skull-base injury patient, and patient has undergone surgery, and patient has a LP fever was there. We have diagnosed meningitis, and he has subsequently gone to brain stem death. What do I do? Say it is you have to find out the cultures and give antibiotics accordingly. When do I say no for organ donation? It is undiagnosed febrile illness, encephalitis, meningitis, or flaccid paralysis, where I do not get an exact diagnosis or exact organism. For viruses, a donor HCV positive may be directed to HCV positive recipient. So I should not say no Okay. Then HBV surface antigen positive, no for organ donation, and HBV core antibody organ may be procured to that respective recipient. Now, a 28-year males will see one case. He has a tumor, he met with accident, and he's been a potential donor. So what do I do? So in case of CNS tumors of low histological grade 1 or 2, or no history of craniotomy, brain irradiation, or ventricular shunts carry a low risk of tumor transmission. So these patients who have not undergone uh, this craniotomy or brain irradiation or ventricular shunts, you should consider for organ donation. Now, if they have histological diagnosis of grade 3 and grade 4, and they have undergone craniotomy and placement of patient, organ donation should be decided with a local procurement team. So it will be individual decision. Okay. So undiagnosed tumors without histological confirmation, consider limited brain biopsy and then go ahead for organ donation. Okay. Now, these are the various basic monitoring systems which we need to be considered in a potential organ donor. So, continuous core monitor, temperature, urine output. Yes, we do this. And goal should be to keep the temperature above 35 degrees and urine output 1 ml per kg per hour. Oxygen saturation also need to be monitored. Routine investigations, what means the important thing is for us, sugar monitoring is important. Then serum sodium should be maintained, and you should do a echo where you maintain the ejection fraction more than 45%. Special management, it is for peripheral warmers, then electrolyte imbalance. So you need to select a proper adequate, a proper IV fluid. Then MAP should be more than 60. Then CVP, arterial pH, nutritional support should be continued. Studies have shown that if you continue the nutritional support or you continue the RT feedings, the organ maintenance is excellent, and the recipient is the results of organ acceptance or graft acceptance is also good. Antibiotic routinely is not recommended, but if you suspect some infection, you need to give antibiotic as per your local culture or ICU. Okay. So routine care, that is change of position, that is decubitus ulcer, then skin care, dressing changes, Foley's care must be meticulously done by a nurse to prevent the transmission of infection or hospital acquired infections. Then, as I said, routine monitoring, ECG, blood pressures, pulse oximeter, and core temperature should be done. So what we leave behind is not what is engraved in the stone monuments, but what is woven into the life of others. So this is life after that. Thank you. Thank you very much. We can definitely save multiple lives. So one organ donor can give 8 organ transplantation, right? Starting from cornea and to the ending up to skin. So this is the way we can help to maintain a potential organ donor. Thus, the vital role of the intensivist arises so that we give a proper care for the multiple recipients on the other side. Thank you. Thank you very much.
Okay, thank you, ma'am. Can you stop the share screen?
Yes.
Very exhaustive and practical tips, ma'am. You being an expert on this, thank you very much. So, any questions? Please put up the questions you have. Just one question from my side, ma'am. You are being an expert of the medical legal law. If the patient is declared brain dead and we are not going to procure any organs, is it okay to disconnect the ventilator? What is the
So actually what has happened is Dr. R.K. Mani, his article, one of his article has said that there is an arrangement, but practically we do not allow withdrawal is not allowed. Withdrawal is not allowed. So we need to give counseling to this patient about various palliative cares. So this is the loophole which the law has given. But in India, withdrawal and withholding is not allowed. So we have to counsel the patient about the grave prognosis and whether they are willing to advancement, or whether you can upgradation of treatment is not allowed for them. So we give them option of palliative care, upgradation of the treatment. So accordingly, they gave us consents. So legality comes in between withholding and withdrawing. There is a thin line. Still, ISCCM or critical care members are fighting for that. And if it is, then it will be added in the amendments subsequently. Okay.
Yeah. Thank you, ma'am. That's what. Thank you very much. So there are no questions, ma'am. Thank you very much. I think we'll end the session. Thank you very much.
Okay. Thank you. Thank you very much.